Welcome to an MS Views and News educational program. This program is called Compass to MS Care. Okay, and we've been doing this program in rural and underserved communities around the United States for the last 5+ years. We will always continue to do this because there is always rural and underserved communities. So we're providing, valuable information which patients need concerning resources and why they should be doing certain things that maybe their general neurologists from those areas have no clue what really to recommend for their MS patients. So today's program, we are featuring Dr. Carina Siracusa. She's a pelvic floor specialist, a bladder specialist, a physical therapist. She just does a lot of different things. So I want to let you all know first, we are supported by a lot of different pharmaceutical. Why? Because they know about our programs, they know about what we're doing and what we're able to provide for everybody. And so for today's program, we have support from EMD Serono, Genentech, Biogen, Novartis, Bristol-Myers, Squibb, Sanofi, and Banner Life Sciences. And I tell you all this because they should be recognized for, what they do to support our programs. Exhibiting today, we have Bristol-Myers Squibb, Banner Life Sciences, Genentech, and Janssen. So, we're glad that they were here and able to give you all that are in attendance, the information that they're able to give you about the medications they have. Let's get this program started. So, Dr. Siracusa, come on up. Thank you.
Thank you very much. So I'm going to be talking to you about two main topics, two of my specialties today, wheelchair prescription and pelvic floor physical therapy, which you may think really like, why is she talking about two completely different things? But in the end, they both have to do with butts. So that's why I kind of am a specialist in both. You'll see a lot of extra letters after my name. I am a doctor of physical therapy, but I am also board certified in both pelvic floor therapy and oncology physical therapy. I'm about a year away from having more letters after my name because I'm getting a second doctorate in education. I say that my goal is to have more letters after my name than in my name. So at that point, I'm done. I will have officially gotten through everything. So let's start with wheelchair prescription, because I work in our wheelchair clinic. I've headed it up for about 10 years. I work here in Columbus for Ohio Health. And I like to talk to people about what is required to get an assistive device. And when I say wheelchair, I mean all manner of wheeled mobility. So that might mean a scooter, that might mean a manual wheelchair, or a power wheelchair. So I just wanted to talk to you and give you some information about the types of assistive devices that you can get, why your physical or occupational therapist might recommend one over the other, and unfortunately, some of the insurance hurdles that you have to jump over or through or what under in order to be able to get an assistive device, because it has gotten a lot harder to get any sort of assistive device, any sort of wheeled mobility. There are very specific rules that the insurance companies have put in place. You can actually, the need for all these people on this team, you can blame it on the scooter store because they committed a lot of Medicare fraud in their day. And so now all of the insurance companies are really heavily scrutinizing any sort of request for a wheelchair. So that's why they put into place this team. So who's on our evaluation team? First and foremost is the DME supplier, so durable medical equipment. Most hospitals do not have a DME license, meaning that even though your neurologist may say, yes, you need this wheelchair, they can't vend it to you. So the DME supplier is kind of our intermediary. We're the medical team saying, yes, you need this piece of equipment. They're the ones that submit everything to your insurance company and make sure that, all of our paperwork is in so that you can actually get it. Now, because of that very large lawsuit with the scooter store and Medicare, they have started to require that you have an evaluation by a physical or an occupational therapist who has a specialization in seating and mobility. And the reason for that is they want to make sure that the equipment is getting into the hands of the people who functionally need it. And so what I mean by that is I would love for us to all have a scooter to be able to tool down the street and get to the grocery store. But if you have a car, then you don't need a scooter for that, right? So that was the problem, was that a lot of people were trying to use the scooter as like almost like a recreational vehicle. And so they wanted us to make sure that people who needed it actually were getting it, and not the people who didn't need it were not bilking the system, essentially. Another person that has to be on the team but actually can be a dual role of some of these other people is the ATP. And that stands for Assistive Technology Professional. And that role is usually either held by the physical or occupational therapist or the DME supplier. And again, they're the ones that help write up this paperwork. So their specialty is more in kind of how to get the insurance companies to approve this. Obviously, the patient is a huge part of the team. So the first thing that I ask anybody coming through my door when it comes to technology prescription is, what do you want today? What are you having trouble with? What are you looking to get? Sometimes patients come in and they tell me, I don't know. I have no idea. I want your help. Other times patients are pretty, definitive that they want some sort of scooter or they want a wheelchair. So then it's my job to figure out what they're eligible for via the insurance company, and then, what we're going to be able to get them to help them be functional. And then also your family is really important, and caregivers, because while those scooters are great, you might not always be able to break it down and throw it in the back of the car. So I want to make sure that whoever is with you and might be helping you put some of this equipment in your vehicle is going to know how to use it and feels comfortable using it, feels comfortable servicing it if they need it, all those types of things. All right, so it is a process now to get any sort of assistive technology. So when I say this process, I don't mean something simple like a walker or something like a transport chair. If you can go and buy it at Walgreens, obviously you don't have to go through this whole process. But if you want something that's going to be paid for by your insurance company, then you definitely need to make sure that you're going through this process. The other thing I try to tell every patient that walks through my door with MS is that you have to remember that whatever we get you, your insurance company is only going to pay for a new one once every 5 years, which is really hard for us, because if you even think to where you were at functionally 5 years ago today, it's probably very different than how you are right now. And so we have to kind of have a crystal ball and look into the future and think, what is going to help you and sustain you for the next 5 years until you are eligible for something again? And so what we'll kind of do is we look at how your disease progression has been going. How were you 5 years ago? Have you not had very much change? Is everything looking good on your recent scans? Then we have a better idea. If things are a little bit more unstable, we may recommend a device that's maybe a little bit more heavy duty than you were thinking about, or a little bit more advanced than you were thinking about, just so that we know that you're going to be able to continue to do this. The other thing that I usually tell patients is when we are going through this process for wheelchair prescription, I ask you to tell me what you look like on your worst day. Okay. I don't want to prescribe a piece of equipment for your best day, because then that piece of equipment's not going to work for you on your worst day. And on your best day, I want you up walking around. I don't want you necessarily using this piece of equipment unless you have to. I want this piece of equipment for those days when your fatigue is awful and you still have a lot of things to do, or when you know it's going to be 90 degrees outside and you still want to go with your grandkids to the zoo. I want to make sure that you can use it for those times and not just your best days. So the process is you have to come into that evaluation with a physical or an occupational therapist. Now at Ohio Health and Ohio State here in Columbus, our clinics are kind of a one-stop shop. So we have many of these things all at the same visit. If you don't live in a bigger city, you may have to do some of these steps individually. So you may have to see the PT or OT at one visit, the DME supplier at a different one, and then the physician at a third visit. But if you can make it to one of the larger hospital systems for your eval, it's a one-time eval. You only have to come once, and you can sometimes get all of this done all at the same visit. So after you work with us at that visit, the physical therapist or the occupational therapist, we have to fill out a whole lot of paperwork. So the forms are between 16 and 20 pages that we have to fill out to justify to the insurance company as to why you need this piece of equipment. So some of the things that we are writing in the forms and some of the things that we may look at during the eval. If you can move from sit to stand, we'll ask you to do that. If you can take a few steps, we'll ask you to do that. We may test your balance. We are going to test your strength in all your extremities. If you've never used an assistive device before, we're going to put you in one just to make sure you're not going to run down small children in the street, and that you can drive it. I have watched our clinic walls are very banged up from very poor drivers. So we make sure that you are going to be able to use that piece of equipment, because the last thing I want to do is have somebody's insurance company pay for a $40,000 chair that then sits in the corner. All right. So we want to make sure you're going to be able to use it. Then once we fill out those forms, they're sent to the physician. And again, in some clinics like ours, the physician is at that same visit, so they sign everything at the same time. If you have Medicare and you're not going to a one-stop shop clinic like ours, you have to see your doctor for what's called a face-to-face visit within 30 days of the visit with the physical or occupational therapist. If it's outside that 30-day window, your visit is considered timed out and you will have to redo that first visit. So again, that's one of the reasons why, especially if you have Medicare or Medicaid, it's best to try and come to one of these clinics that does everything all at once. Once the patient has seen the physician, they sign all those forms, and then we forward everything on to the durable medical equipment company. They're the ones from there that submit everything to the insurance. And this is their job. So they know ahead of time what your insurance company is going to pay for and what they're not going to pay for. So there are some fancy bells and whistles or really fancy wheelchairs out there. And not every insurance company will pay for every single one of those. So we know ahead of time, and those DME companies know ahead of time, like, listen, your insurance company is going to say you don't qualify for that. So just know that we usually try to kind of head some of those things off at the pass, but then they also know what kind of language we have to use in our paperwork that helps your device get approved. Then, just like with anything else in the, kind of medical continuum, you have an allowable for it. And every insurance company has a different allowable. So just like you go, have a procedure at the hospital bills one amount, the insurance company comes back and says, nope, you can only charge this amount. The DME company will figure out that allowable, and then they'll call you before they ever order anything and tell you what your out-of-pocket might be for that. So usually, for Medicare, the same rule applies. So 20% is what you will owe if you don't have a secondary insurance. And what I can tell you is the fully loaded wheelchairs retail, obviously this is not the price the insurance company charges, around $36,000. So if your allowable is close to that, you're going to owe around $6,000 for that wheelchair. Even a really good manual wheelchair is about $3,000. So you're looking at least $600 that you might owe for that chair. And I think that's a big surprise. That's why I like to tell people about this when I do this talk, because I always think that's a big surprise to people. They assume that, I have MS, my insurance company is going to cover this whole thing. And that's not always the case. You may have a copay. Most DME companies will work with you, though. So the two that we work with the most here in Columbus, National Seating and Mobility and New Motion, which are countrywide companies, so they're all over. They have payment plans for those copays, so they will usually work with you if it's a problem. Then once the insurance company has approved everything, and once you have said, yep, we're going to cover the copay, then they go ahead and they start ordering things. Now, that insurance process can take anywhere from 30 days to 90 days. Okay, it's very frustrating for us, and it's very frustrating for you. And then on top of that, once the insurance company has approved it, then those parts have to come from multiple different parts in the country. So, for instance, Tylite manual wheelchairs come from Seattle. Permobile power wheelchairs come from Nashville, Tennessee. The Roho cushion comes from Missouri. So, you have kind of different things coming from different parts of the country. So it usually takes about 2 to 4 weeks for them to get all of the parts, build the chair, and then deliver it to you. So in most companies will deliver the wheelchair directly to you. Once you get that wheelchair, if you are having trouble using it, most physical therapy clinics have a program where we will teach you how to use that wheelchair, teach you how to do fancy things with it. All right, so just to talk about the different types of chairs is kind of the other thing I wanted to include in this. So this is probably the most basic chair. It's called KO1 chairs. This is your transport wheelchair that you get at Walgreens. There's nothing fancy to it. We really do not recommend these. These are for you broke your ankle, you can't walk for a little while, you need to be pushed around. That's all this is for. So we try to really not include these or use these as much as possible. And because they are usually under $100, we usually tell our patients with MS, buy this out of pocket if you can. Don't have your insurance company pay for this because they will count this in that 5-year rule, and then you will not get anything else. So I tell them, pay for the $75 chair at Walgreens, and we'll get you the more expensive one when and if you need it. This is kind of your standard hospital chair. So this is kind of what you see at the entrance to the hospital when you pull up sometimes. This is a transport chair as well. It is meant for short-term use or people that have orthopedic issues, again, like a broken leg or a knee replacement. So we, again, do not usually dispense these. K3 is also a very kind of basic chair. Again, we do not usually dispense these because they're heavy and they're really hard to maneuver. So these are for somebody else to push you around when you broke your leg. So now here's where we start to get into the manual wheelchairs where we would prescribe for somebody with MS. This is a K4. This is called a high strength, lightweight wheelchair. And it has some adjustability to it. So we can put a nice cushion on this type of wheelchair. We can put either a soft back or a hard back on it. It has some adjustability, but it is not the lightest chair that we have. So it is light. It's lighter than those first 3 that I showed you. But we usually only give this one to somebody who does not have a neurologic diagnosis because there's not a whole lot of things that we can add to it later on down the road if they do have a little bit of advancing of their disease. So this is somebody who's fairly stable, like Parkinson's or CVA. Believe it or not, the insurance companies don't count Parkinson's or stroke as a neurologic diagnosis, which I always think is hilarious. Welcome to my job. This is what I deal with. MS, luckily, is definitely considered a neurodiagnosis. So you would qualify for our most the lightest chair and the most advanced chair technologically. So this is what we call a K5. It is ultra light. So the reason why we like this one for our patients with MS is that it is the lightest. And so if you are still able to stand, you could probably, even if you have fatigue, you have weakness, a lot of our patients can still lift this up into their vehicle quite easily. There's 2 types. There's what we call rigid and folding. Folding obviously folds in the middle. Rigid, if you want to put it in the back of your car, you usually take the wheels off. Now, the only main modifier to this from an insurance company standpoint is that you have to be able to transfer into this type of chair independently, meaning just not using a Hoyer lift. So it doesn't mean you have to stand and then sit. It means you can also like scoot over into the chair, pop over from the side. You just can't need a lift or need somebody to lift you into this chair. That's the only other insurance qualifier besides that neurologic diagnosis. The nice thing about this chair is that after you've used it for a year, then you also qualify for something called Power Assist. And what Power Assist is, it's essentially a little wheel and a power pack that attaches to the back of this wheelchair that turns it into a power chair. So it comes with a button and it also comes with a smartwatch, both which control it. And again, the insurance company does require that you've used this for at least a year in order to be able to qualify for it. But I have a lot of my patients with MS that love this because you can still fit a manual wheelchair into a regular car. A fully loaded power chair or even a regular power chair, you pretty much need a van or a hitch or some sort of specialized vehicle in order to transport that. But if you have a manual chair with a power pack on the back of it, you can throw that in a trunk. So a lot of my patients with MS love this because it's kind of a middle ground between the power chair and the manual chair. All right, let's talk about power chairs. So we call a power chair anything with a battery, basically. And so the first is called a power operated vehicle, otherwise known as a scooter. So the power operated vehicles, the main criteria from an insurance standpoint is you have to have the upper extremity strength to operate the tiller. So one of the things that we're going to check out with from a physical therapy standpoint is, can you get your arms up to at least shoulder level, right? And you can hold them there and then you can turn. So if I have a patient, for instance, that has a lot of hemiplegia, so a lot of spasticity in one shoulder or can't get that shoulder up, then I can't allow them to get a scooter. Functionally, though, the other thing I want to know is that your balance is at least halfway decent. Because if you've ever gotten on one of these at the grocery store, it's not exactly easy to get in them. You know, you have to be able to lift that that armrest up and get both legs up onto the foot platform. Most people can, but occasionally we'll have somebody that looks like they're going to trip trying to get into one, and so then I can't say that they would be able to get in and out of it safely. And so then if that's the case, we might go ahead and recommend kind of the next category up. The other thing is too, I will say you do have to have at least halfway decent kind of trunk balance to use one of these, because it's basically an office chair on motorized wheels. All right. So if if bumps or anything kind of increases your tone, or you get really, really tired sitting in a regular chair all day, we may recommend going up to the next class of chair, which is what we call a group 2 power wheelchair. There's very little ability to change. Usually our options are red or blue when it comes to this chair. There's not really going to be anything else that we're going to be able to do to change it or modify it. But it's a lot easier if you have balance problems, transfer problems, anything like that. It's easier for you to get in and out of something like this than it would be for you to get in and out of a scooter. So I have had some patients that have come into my clinic really thinking that they want a scooter because they want something that they can break down and put in their trunk. And we've said, you know, you're really, from a functional standpoint, I'm very worried about you falling or not being able to get in and out of this. And so we've moved them up to a group 2 power wheelchair. Now, the kind of biggest class or most expensive class of power wheelchairs is what we call a group 3 power wheelchair. The main criteria for this from an insurance standpoint is that you do have to have a neurologic diagnosis. MS does qualify for this wheelchair. So the biggest thing with this chair is we can add a lot of bells and whistles to it. So it can have things like tilt, meaning that the seat and the back tilt all the way back. power elevating leg rests. It can recline. It's like a lazy boy on wheels. So it's definitely for my patients that are not really walking at all, are using that chair as their primary form of mobility, have a lot of increased spasticity, have a lot of issues with mobility, then we're going to usually move to this type of chair. So this one is the most expensive of all the wheelchairs. It is definitely, there's a lot of variability in it. We can put fancy cushions on it, fancy backs. If we have people that are having difficulty speaking, we can mount devices onto it. The really cool thing about it is it also has a Bluetooth monitor in it, so you can use your computer, turn on your lights, turn on your fan, turn on your TV from your wheelchair. Your wheelchair can control your entire house. So it is nice. The technology has come a long ways. Even since I started doing it, I graduated in 2005, and they didn't have all of the fancy things that they do now. So again, this is one of the options. So just in summary, before I move on to the next part of my talk, from a wheelchair standpoint, no matter if you're looking to get power or manual, you definitely have to talk to your physician first, and I highly advise you to find a wheelchair clinic. So there's a wheelchair clinic in Zanesville. There's a wheelchair clinic in lots of rural areas. So if you talk to your family physician or you talk to your neurologist, they probably should be able to direct you to a wheelchair clinic in your area or not too far from your area. And that's the other reason why I recommend that is even though any physical or occupational therapist can write up one of these evaluations, those of us that work in the wheelchair clinics, we know how to get around all the insurance hurdles. We know the right language we have to use. We know what has to go in that note to basically, I don't want to say trick the insurance company, but that's what I feel like we're doing sometimes with these. And so, we really try to make sure that you're going to get this on the first try, and we're not going to have to go back and appeal it multiple times, which can happen if you go to a therapist that maybe has not had the same amount of experience with writing these up. So insurance has really strict rules, and I have had patients come in and say, hey, I would really like this or that, and I have to tell them that their insurance company will not cover that. Most DME companies will have a clause to pay out of pocket at basically the market price. So for instance, in a power wheelchair, in those group 3 power wheelchairs, there's something called a seat elevator that basically lifts you up so that you can reach all the high cupboards in your house and move around. Insurance has decided that that is not medically necessary, and so they do not pay for it. Very frustrating, very frustrating. But there are grants. So New Motion, for instance, has a grant for patients with MS to get that for free. So then we get all the paperwork together for you, apply for the grant, and then you can get that added on to your wheelchair. So again, that's why it's good to come to the clinics, because we know what's out there, which of these grants are out there. Talk to the therapy team about the pros and cons. Again, we really we're very well versed in the pros and cons of each of them. So if you're unsure, that's part of what is that wheelchair evaluation, is us sitting down and talking to you about, what type of home do you live in? Do you live in a rural area? Do you live in the city? Where are you primarily going to be using this? And then we can best fit the device to you. And then don't forget about transportation, because that device is great, but if we can't get it in your car, then you're just going to use it at home. So just remember to think about that when you're thinking about what kind of device you want. All right, so then we're going to talk about my second butt-related topic, which is pelvic floor physical therapy. How many of you here have heard of pelvic floor physical therapy or seen a pelvic floor PT? Yay! That makes me very happy. So I run our pelvic floor physical therapy program at Ohio Health. I have been doing it for a very long time. So I just wanted to give you an overview of what pelvic floor PT is, but specifically the things that you should be thinking about in related to your MS. So these are your pelvic floor muscles. So your pelvic floor muscles run from sit bone to sit bone and pubic bone to tailbone. So they form a bowl in the bottom of your pelvis, and they have multiple functions, and they are very important. I mean, I'm a little biased, but I do think they're the most important group of muscles in the body. But you can see that in this particular model, you can see the area around the anus where there's a sphincter, and then the area around the urethra where there's a sphincter. So their main purpose is to keep us continent, all right? They help us with our bladder and they help us with our bowel. There is really only minor differences between the male and the female pelvic floor. The main difference is women have 3 holes because we have one that the baby comes out of, and men only have 2 holes. Other than that, the muscles are pretty much the same. So I am doing very much the same therapy, whether you are a man or a woman. The only thing is that if you have had a history of childbirth in your past, then it may make the muscles a little bit weaker. Men, their issue is with the prostate. So if you have BPH, where your prostate has swollen up a little bit, or you've had prostate surgery, that's where you might have some increased issues with your pelvic floor. All right, so let's specifically talk about the bladder complications of MS. What I always say whenever I'm working with a patient with MS when it comes to their bladder is that your pelvic floor and your bladder had a life before you were diagnosed with MS, all right? What I mean by that is you may have had a baby. You may have had chronic constipation. You may have had pelvic floor surgery. And so some of the issues that you're experiencing might not be because of your MS. All right. I think, unfortunately, what happens is a lot of people will blame it on your MS. Physicians, especially primary care physicians, may blame it on your MS, but that's not the case. I just had a patient that this happened to. I just evaluated her last week where she was complaining a lot of pressure in her pelvic floor and her bladder. Her physician chalked it up to her MS. And when I did her exam, I said, nope, this is because you've had a baby and you had a tear with your baby, and that is exactly why your bladder is doing what it is. So that's really what I'm trying to tease out as a physical therapist is, is this because of your MS and we may need either medication or different strategies, or is this more because of just the life of your pelvic floor? However, that being said, bladder issues are experienced by up to 98 or 96% of patients with MS. So every one of you, your neurologist should be asking about your bladder. And if they're not, then you should be bringing up your bladder in your appointments with your neurologist. The other problem that we see is often those bladder issues are not reported until up to 10 years after they've started experiencing them. And no one should have to leak that long or have urgency, be running to the bathroom that long before they talk with their neurologist about it. So again, your neurologist, your PCP, they should be bringing these issues up. They should be asking you about your bladder at every single visit. The most common complaints that we see as far as the bladder is concerned are urgency and frequency, meaning when you gotta go right now. Do you have a question, Stuart? Okay. 5 minutes, yep. So urgency and frequency, so, kind of running to the bathroom, and then urgent continence, so leaking before you get there. Or probably my most common complaint, which is I'm going to pull my pants down and I start peeing, even though I'm trying not to. Other complaints that we don't see as often, but still can be related to MS, can be hesitancy, which is you're sit down to pee and you don't necessarily, you're not able to go right away. Interrupted stream or incomplete emptying. The need for double voiding, meaning you stand up, you got to sit right back down again. Nocturia, which is getting up in the middle of the night to pee. And enuresis, which is actually having an accident while you're sleeping. You can't really rely on subjective history, meaning you can't really necessarily always rely on what you're feeling, because part of it is that your bladder is not sending the appropriate signals to your brain when you have MS about how full your bladder is. And so that's why most neurologists will get what we call a post-void residual, meaning they scan your bladder after you've peed to really see if you're fully emptying. Also, the greater disability and recent relapse are associated with the odds of being bothered by bowel and bladder issues. So most of my patients will have had a recent relapse, and then that's when they do report things to their physician. And then that PVR might be the only test that neurologists do. All right, so we can usually break bladder dysfunction into two categories. So one is the muscle is the problem, and two, the bladder is the problem. So if the muscle is the problem, we're going to see things like stress urinary incontinence, where you cough and you pee a little bit. I already mentioned your urge urinary incontinence, bladder pressure, and prolapse pain. So any of those are going to be really greatly helped by pelvic floor muscle strengthening, which is partially Kegels, but not just Kegels, because if all I did was tell people to squeeze and relax all day, my job would be super boring. So we do other exercises to also help with that. And then visceral means that it's due to your bladder. And so that you might need medication for. And sometimes it's a combination of needing both in order to improve function. And then last, I want to talk about bowel dysfunction. The most common bowel dysfunction in patients with MS is constipation. It's the most common bowel dysfunction in the general public as well, mostly because we're not eating enough fiber. You all ate salads, so I'm happy you got some fiber in today. And you're not drinking enough water, because guess what? That fiber doesn't work without water. So we need that water in order to make that fiber do well. Honestly, bowel dysfunction happens and constipation happens most often because of behavioral issues. So we're not moving enough, we're not eating enough fiber, drinking enough water, we're drinking too much pop and not enough water. All of those things are going to contribute to constipation. We're sitting poorly on the toilet. I talk about toilet posture all day long. The squatty potty is great, but that's the reason for a lot of the bowel dysfunction. There are two types though. So one is dyssynergia, and again, that's muscle. That's where those muscles are not relaxing like they should. And the other one's slow transit, and that's when your colon's just kind of slow and sluggish. Impactions can also happen due to constipation. It's rare, but I like to mention it. And so that's long-term constipation that leads to eventual impaction. Oh, I did include some stuff about sexual dysfunction, so we're going to talk about that really briefly. So a couple of factors that affect sexual function in MS. Fatigue's probably the biggest one. If you're too tired, you're probably not going to be super excited about sexy time. Spasticity and pain also can impact sexual functioning. Bowel and bladder, if you're worried about leaking, that's going to impact sexual dysfunctioning. And mood disorders, because many of the things we put you on for depression lower your sexual drive. So that also can impact. So the incidence of sexual dysfunction in MS ranges from 62 to 83%. In men, erectile dysfunction will occur in about 70% of men. The mean time of onset between MS and erectile dysfunction is about 9 years. The ability to sustain an erection is largely dependent on psychogenic erection drive, meaning that what you're looking at turns you on. So that is a big part of it. And Viagra is the most common treatment for men. Sexual dysfunction in women tends to happen due to diminished lubrication, sometimes if they have a lack of sensation. Unfortunately, there are very few treatments for sexual dysfunction in women that in women, period, but also women that have MS. If they do have bladder dysfunction and we cure the bladder dysfunction, that can help with some of that sexual dysfunction. So what do we do for all of this from a pelvic floor standpoint? I saw that many of you are familiar with what we do, but these are some of the things that we will ask a patient with MS. So to help tease out where that's coming from. When did the symptoms start? What are they? How are they dealing with those symptoms? Are they changing their behavior based on those symptoms? What medications are they on for their MS? Because that can have an effect. And what medications have they tried for their bowel and bladder symptoms in the past? We may give you what's called a bowel and bladder diary and have you track your bowel and bladder function for at least a couple of days. And that can help us to figure out what's going on. So that's a common bladder diary. The physical therapy treatment that we do food and fluid management, so making sure that there's enough fiber in your diet and water. We may do things like bowel massage, exercise, mobility considerations, and we may look at whether or not you need to be cleaned out from a bowel standpoint. So again, we go over all of these things. That's my correct toilet posture. You see kids, when babies need to poop, they always squat. It's because they know that that's the best way to poop. All right. Your bowels relax, your muscles relax when you're in that squatted position. So we also do Kegel exercises, as I said, core stabilization exercises, pressure management, meaning teaching you how to bear down properly, and then breathing exercises. So that's just a little bit about pelvic floor physical therapy and device management. So I will open it up for questions. Sorry, I took you by surprise.
You got me totally by surprise. All right, great. Thank you very much for that, Dr. Siracusa. Sorry, you really got me messed up here.
I'm sorry. I'm
going to go around to the audience. I'm going to go around to the audience in a minute. There are questions, though, that came in online, and I figured while I'm sort of squatting over here, let me get some of these questions first, all right? Can someone who is ambulatory for short distances and still works but would like a power chair or scooter for long distances, is it possible for insurance to pay or help for it? I would like to get one, but not possible unless someone pushes a chair.
Yeah, so that's a great question. So a lot of my patients with MS are ambulatory when they come into my clinic for a powered device. What I always tell them is, tell me what you look like on your worst day. All right. So if on their worst day they're having trouble walking across the room, then I absolutely can get a power mobility device. The one insurance that is a little tricky is Medicare, because Medicare, unfortunately, doesn't care what you do outside the home. They only care, can you move around in the home? And as a PT, that personally offends me, but I have to work it within those Medicare guidelines. So again, that's why I say, what do you look like on your worst day? Because probably on your worst day, you have trouble walking around the house. And so, yes, you can, but you have to go to a PT that's going to really know how to ask those questions appropriately and understand how to get that funded by the insurance company. So call up a PT, go to a wheelchair clinic, ask your neurologist for a referral to the wheelchair clinic.
Awesome. Great. Thank you for that. Next, again, before I go out to the audience here, I'm just going to ask a few more questions that came in online, and then I'll go see the audience, then I'll come back to the questions online. All right. Jennifer writes, I just got one of those fancy wheelchairs and my insurance was billed almost $60,000. I don't remember what they paid out or why they paid that out. I paid out a pocket for the scissor lift that they wouldn't cover.
Yep. Yeah, so that was the scissor lift is that seat elevator that unfortunately, because Medicare deemed it medically unnecessary, all the other insurance companies did basically say they wouldn't pay for it. Now, a power chair, a fully loaded power chair can cost up to $60,000 because the base of the chair is about $36,000. And if you have to add on a headrest and a backrest and a good cushion and extra actuators vibrators to do all of the different bells and whistles, it can. So again, though, most of it's like anything else. If you look at what your drugs actually cost and your infusions actually cost, it's about the same thing. But we also liken it to a car. If you're really using a power chair, you're using it pretty much all day, every day, probably more than your vehicle. So that's part of the reason why it costs so much.
I got a good question to ask that's pretty stimulating. So let me ask this question from a person online. And can vibrating sex toys help women regenerate sensation in the areas required for sexual satisfaction? My husband found this website. Sex doctor claims that these things will fix MS issues in this area. I think it's all bunk. What's your opinion?
Vibrators is bunk. That's a great question. Yes and no. It's not all bunk. What I will say is vibrators absolutely can help, but there's a lot of other things that you also need to talk with your neurologist about your sexual dysfunction first before moving to something like that. So one, is your spasticity under control? Because if your spasticity is not under control from a nerve standpoint, the main nerve that supplies your clitoris or your penis may be basically impeded with blood flow, and so then that sensation is going to be altered. So spasticity definitely needs to be under control. The other thing I often say is too, if you are on anything like Cymbalta or any of the depression meds, that might also be lowering your drive and lowering some of the sensation. So work with your neurologist and talk to them about what medications you're on that might be also decreasing some of that drive and sensation. That being said, a good pelvic floor therapist can work with you on the right sex toy, because there's a lot of them on the market, and this has become also a very kind of like hot topic. Double entendre there, as far as what you should and shouldn't be doing. And so pelvic floor physical therapists can look anatomically at what's going on, what nerves are affected, and whether or not vibration might help you. But I have a lot of patients that it really does help. And I also know all of the discreet places to order those vibrators, so they don't come in a big box that says vibrator on your porch. So just make sure I can help you with all of that from a pelvic floor therapy standpoint.
Thank you very much. That was very stimulating. Thank you. All right. We have a question in the back, but for anybody in the room with a question, please hold your hand up and so I know where to go to. All right, great. I know where I'm going to next.
I have several questions, Carina, but I'll start with one. What's your opinion of a travel scoot?
A travel scoot? Is that the wheelchair? It's like a manual wheel, the folding power wheelchair?
No, it's a scooter.
Oh, the scooter. You know, scooters I think are good if you can functionally get on and off of them. The other thing, though, is I caution people on purchasing DME devices from an online source, because the problem is if it breaks down, you might not be able to get it serviced. So we usually recommend more of like the Drive scooter, the Jazzy scooter. Those are a little bit better just because I know around here if you need a new battery, who can get it for you real fast. So it's not that they're a bad product, it's more that service aspect of it.
Yeah. What she was referring to was something called Travel Scoot USA. It's actually made in England. And
Yes.
It's a very lightweight scooter.
Yeah, now I know which one you're talking about.
It's aluminum based. It's 26 pounds altogether.
Yeah.
And they are based in the United States, and they give you a full list of everything available.
Yeah, like I said, that's usually the hardest thing is the service, because I know none of my vendors around here will service something like that.
Right.
So again, it's not that it's a bad product.
Right. All right, thank you. Next question's from here.
Hi, I have a wheelchair, and I was wondering, because the 5th year is almost up, so I just can't get a wheelchair. You've got to be an attorney and use the right words and try to get me another one?
So no, you don't have to be an attorney. You just have to be a therapist. So just to talk, what I would say is if you're on that 5th year, is if it's time to go ahead and get one, talk to your neurologist about referring you to a wheelchair clinic. So again, there's 2 main ones here in Columbus. There's Ohio Health, and which obviously I'm a little biased for that one. But Ohio State also has a wheelchair clinic. And again, if you go to either one of those, they're going to work with you, sit down, ask you a whole bunch bunch of questions, do an eval, and then we're going to do all of the leg work to basically get you that new wheelchair. But you just need a good therapist.
I've had back surgery, and when I sit, it feels like I'm sitting on something and it's jigging up. Is there something that I can do to help me with that pain?
Yeah, absolutely. So often that feeling of having a foreign body in your rectal area, very, very common after surgeries like that. That's due to actually a muscle spasm in the pelvic floor that I showed you. So going to pelvic floor physical therapy can help with that, can decrease that, because we work on different stretches. We do internal work. So we do either do intravaginal or intrarectal work as well. To get that muscle to relax. But and then if it's really, really serious, sometimes we'll do Botox in that muscle as well. But you can get that pain to go away.
What can you do to stretch the bladder so that it will hold more fluid before you evacuate?
That's a great question. So from a bladder standpoint, it is hard to stretch that bladder. So one, I always need to know, first and foremost, you should have what's a test called urodynamics from a urologist to give me what your actual bladder capacity is. And then what we do is we basically, I call it timed voiding or potty training for adults. So we try to progressively make sure you're drinking the right amount of fluid over the right amount of time and trying to hold that urine and not go at that first moment of having that urge. So we have lots of urge suppression techniques that helps that. Now, if that something like that doesn't work, then that's where we may refer you back to urology, because Botox is actually the thing that really helps us to increase that bladder capacity. The only bad thing about the Botox is that you may have to cath for a little while, especially in the first 2 months after having the bladder Botox, because your bladder, it makes your bladder so flaccid that it won't completely empty. But it has really great results for increasing bladder capacity. I've had quite a few patients that have done very well with it.
Great, thank you. From back online is a Carol asking, what is the cost of pelvic therapy and who provides it? Does insurance cover this?
Yeah, that's a great question. So it's just physical therapy because I'm dealing with the muscles. So it's just like any other PT appointment. It's just that I make you take your pants off. None of your other PTs should be making you take your pants off. So if they do, be very concerned. But pelvic floor physical therapy is absolutely paid for by insurance. So again, you do need a prescription from your physician. Your neurologist should be able to write that for you. Your primary care doc, if you're going to see a GYN, they can write it for you. But I would definitely make sure that you are trying to find somebody who is well trained and has experience with MS. Not every pelvic floor therapist does. Most of the ones that work for hospital or university systems have had the full training, but all you have to do is call. And if you, I've got my contact information up here. I teach a lot of the pelvic floor physical therapists. And so even if you're not going to come see me, I have a lot of resources and a lot of people that I know that I can say, like, these people I know have experience with MS. Just because you don't want to have to answer a lot of questions that are not going to be pertinent to what you're going happening with your MS. But absolutely, it's paid for.
Great, thank you. And Carol also says, how can we see a better overview of what Dr. Carina provides with regard to pelvic floor therapy? And my answer is that Dr. Siracusa has spoken for MS Views and News in the past, and we do have PowerPoints of hers on our YouTube channel. And if you cannot find it and you wish to see it, you could send me a text message or an email, and I will send you the correct link. Okay? All right, great. Next, Carina, for everyone out there, my dad and I both have MS. My dad's 83 and he uses a power chair and the elevating seat. And one of his jobs is unloading the dishwasher that allows him to do it. So that's what that power chair does for him. So she just wants people to know that it is great use. All right. Next question is from a Rhonda. Urine issues have E. coli in them. What can be done?
Yeah, so first and foremost, you got to knock out that E. coli. So there, you're going to work with your urologist from a medication standpoint to help kill all of that bacteria in your urine. What we do from a PT standpoint after that is that a lot of times you will experience a lot of residual urgency and frequency, and you will have developed some very bad habits from having that that cultured bacteria in your bladder, and so we help kind of correct all of those. But you have to work with your urologist. The only thing that can knock that E. coli out is antibiotics and medication.
All right. Next question. What kind of medications are available for bladder issues?
Yeah, so I don't prescribe the medications. I work with my urologist for that, but probably the two most common that you're going to see for bladder issues are oxybutynin and Myrbetriq. Oxybutynin is one that basically helps to calm down an overactive bladder. It keeps it from contracting. The really bad part about oxybutynin is two things. One, there was a recent study that came out that showed it actually increases cognitive decline in patients that are experiencing any sort of cognitive issues. So we really try to stay away from it if you are having memory issues. And two, it causes horrendous dry mouth. So the way it works on the body is it essentially dries out most of your mucous membranes. It can't work on just the bladder, so it dries out your eyes, your mouth, everything. So Myrbetriq is the one that actually has had much better efficacy for patients with neurologic dysfunction. The only thing that we're finding is that, again, insurance companies, not my favorite, they will deny Myrbetriq until you have failed a trial of oxybutynin. So what we usually do is put you on oxybutynin for like a month and then say, nope, the side effects were horrible, it didn't do anything, and then we go ahead and get that Myrbetriq approved. So that is the only bad thing about it. But it's a lot of my patients have done very well with Myrbetriq once they've been able to be put on it.
So you're talking about medicines for the bladder issues. What are the primary medications available for hormone dysfunction or issues, they write?
Yeah, that's really hard. So, hormones are something that we haven't quite figured out completely yet. So hormonal dysfunction, a lot of times with women, it's a lack of estrogen, but also can be a lack of progesterone. Men, it's usually low testosterone. So I usually refer patients that are having hormonal issues to our endocrinologists, or if it's a female, they might be working with their GYN on that for medications.
Okay, thank you. All right, so Dr. Siracusa, let's give her a round of applause.
Thank you very much.
We want to thank all of our supporters. Of course, we can't do our programs without those that are in attendance, as well as online, as well as in person. So thank you for coming, and all have a great day. Bye-bye.